Yep.
Thank you so much, Taryn. Good afternoon, colleagues. Thank you so much for joining us for this session, which is on non-factor therapy in hemophilia. And Professor Mahlangu is going to present on this session. And my name is Dr. Moses Chatambuza. Greetings from Harare. Today is Africa Day here, so we are on holiday. And this session for Blood SA Foundation is proudly kindly sponsored by Novo Nordisk and South African Stem Cell Transplantation Society. This is our management team that brings us, that organizes such beautiful sessions, which is led by Prof. Estelle Bebeck, and there's also Dr. Nicole and Mrs. Brooks and Taryn. And some housekeeping notes. All our sessions are recorded and can be found on our website on bloodsa.org.za under resources. And kindly during the sessions, please mute yourselves and feel free to add any questions or comments to the chat box. We will respond to them at the end of the presentation. And for CPD points, these will be submitted to the HPSSA for each registered SA attendee. Please ensure that you are attending with your own registered Zoom link and not in a group. And you attend for at least 1 hour, and your HPCSA number is entered correctly when you sign up. You can join our mailing list via our website and also subscribe to Deep Dive or use this QR code. And the Blood Essay and the speakers value your honest feedback. Please complete the anonymous feedback survey at the end of the Zoom meeting. And for our upcoming events, we've got quite a lineup of them. We've got the 2026 Physicians Conference at the Protea Hotel in Stellenbosch from the 4th to the 6th of June 2026. We also have the SASMO and the SASETS on 7th to the 9th of August in Sandton Conventional Center. And as well as the popular 18th Annual Hematology Oncology Conference, which is to be held on this from the 2nd to the 4th of October at the Century City Hotel in Cape Town. And next week, our presentation is Warburg syndrome, and it will be by Dr. Bizarre and Dr. Jasmine. And today's agenda, as we said initially, it's on non-factor therapy in hemophilia. And this is going to be presented by Professor Johnny Mahlangu. And Professor Johnny Mahlangu is a full professor of hematology and the academic head of the Department of Molecular Medicine and Hematology in the Faculty of Health Sciences at the University of the Witwatersrand, as well as the National Health Laboratory Service. He is also head of clinical hematology at the Charlotte Maxeke Johannesburg Academic Hospital. Prof. Mahlangu completed his undergrad and postgrad training in science and medicine at the University of the Witwatersrand, acquiring qualifications as a hematologist and clinical hematology subspecialist through the College of Medicine of South Africa. And his primary area of research focuses on novel therapies for bleeding disorders, for which he has acted as a principal investigator in over 120 international multi-center studies. He has published numerous peer-reviewed journal articles, many in high-impact journals, including the New England Journal of Medicine, the Blood, Lancet, and Journal of Thrombosis and Hemostasis. He has presented more than 700 oral talks and poster abstracts at national and international scientific meetings. His academic citizenship includes 50 memberships of national and international scientific committees, and he has received over 30 honors and awards, including 2 VC awards, as well as national and international academic leadership awards. Ladies and gentlemen, kindly help me welcome Professor Johnny Mahlangu. Prof. Mahlangu, you can start sharing your presentation. Thank you.
Thanks very much, Moses. And I think the presentation is already shared. Are you able to see my introductory slide?
Not yet, Prof. Maybe let's ask
the technical people to read
the technical people to assist. Taryn?
It's not on yet, Prof. I think it was unshared when the intro slides were shared.
Oh, so I must reshare. Okay,
yes,
we can do that. Let's reshare the presentation, and then we can take it from there. You able to see it now?
Perfectly. Yes.
Okay, excellent. And happy Africa Day, everyone, and good afternoon. Thanks for making time to come and listen to this simple hematologist. And the brief here, I was asked to talk about the use of non-factor therapies in the treatment of hemophilia A and B with and without inhibitors. These are my conflict of interest disclosures. Notably, I'm not employed or a shareholder in any one of these partners who I do clinical trials with. This is a disclaimer largely because I'm going to talk about molecules that are not necessarily registered in South Africa and certainly not in the rest of Africa. Just keep that in mind as we are discussing molecules that are still in development, and some of them, in fact, are still undergoing clinical trial evaluation. This is the agenda for today. I'll remind you of the unmet needs in hemophilia and the mechanistic view as to why the non-factor therapies are important. I will touch on the phase 3 clinical efficacy and safety data outcomes using the non-factor therapies. And perhaps more specifically, and I think this is the question that I get asked most of the time, how do you take a patient to surgery who is on one or more of these non-factor therapies? I'll give you at least my thoughts on that. And also, the second most important question we get asked is when someone does bleed and they are on prophylactic management with non-factor therapy, how do you manage them? And I'll give you some thought and some of the data that is actually available in the open space. I always start with my presentation with a reminder that we consider hemophilia as a condition characterized by impaired thrombin generation. This is now in a test tube. One sees upon hemostatic challenge a thrombin burst as a result of the hemostatic challenge. This is in a normal individual. In the case of hemophilia, that thrombin generation is blunted. You get impaired thrombin generation. And in fact, all of our efforts is ultimately to restore the thrombin generation. And it really does not matter what modality of treatment one is using. The convergence is that every single one of them should be able to restore thrombin generation. And that is what we want to achieve, of course, with the non-factor therapy. The second most important element of what I consider to be relevant to hemophilia is to remind ourselves that this restoration, in fact, is now regarded as the standard of care. In other words, prophylaxis that leads to the restoration is the standard of care in hemophilia. It will be remiss of me not to show at least one picture of hemophilia. We do know that the hallmark of hemophilia is hematorosis. Hematorosis often is followed by destruction of cartilage and bone, leading to hemophilic arthropathy and dysfunction, as well as destruction of the joint. Essentially, we're talking about a destructive cascade, which is preventable with replacement therapy. And in the last several decades, at least 8 decades, we have seen this unprecedented evolution of the therapeutic landscape in preventing this destructive cascade, starting with blood and blood products. When Judith Poole formulated the cryoprecipitate, it became the hallmark of using blood and blood products. And of course, with the advent of DNA technology, we do know that now we have better products that do not us able to rely on blood transfusion and certainly donation. We now have recombinant products with modified kinetics, the so-called extended half-life products. And more recently, at least in the last 5 to 10 years, we've seen the evolution of non-factor therapies in this space. And that is what actually I'm going to focus on. And I suppose the most important question we should be asking ourselves, with all of these therapies, why are we developing more therapies? And I just want to remind you that, in fact, the consumption of both factor 8 and factor 9 has been incredible. This is the graph that was put together and published in 2018 by the Market Research Group. And you can see here that, contrary to the prophets of doom that thought that plasma-derived products will disappear, in fact, there was a steady rise in the plasma-derived products, in addition, of course, to the exponential rise in the recombinant factor 8. And that, of course, did not limit itself to factor 8. One sees almost a similar picture for factor 9. And the bottom line here is that as a consequence of this unprecedented evolution, we have actually seen an increase. And the reason we're seeing an increase in consumption is because almost on a daily basis, we're identifying more and more patients. If one looks at what has been the impact of this increase, this has been nicely summarized by Steve Pipe in this cartoon, showing clearly that as a result of this exponential increase, we are seeing a reduction in annualized bleed rates across the board, a reduction in treatment and disease burden across the board, an improvement in quality of life of the patients, reduction in the use of clotting factor concentrate, where patients actually switch from on-demand treatment to prophylactic treatment. And of course, we are also seeing increasingly the change in the mental health of our patients with the desire and the reality of living a hemophilia-free mind, with a reduction in the anxiety that is associated with that. It's not all smooth sailing. We do know that despite this abundance of our therapeutic tools and the full therapeutic toolbox, we have a number of barriers and challenges. And these are listed here. In fact, I summarized this sometime back in 2022. They include, amongst others, the fact that there is an element of treatment burden associated with the replacement therapy, in particular, if one is using replacement therapy requiring intravenous infusion. Immunogenicity is most feared and the most difficult complication of replacement therapy that one has to deal with. Maintaining adequate factor level. You must remember, when one is dealing with replacement therapy, you're creating a pharmacokinetic picture characterized by peaks and troughs, and in fact, the inadequate factor protection comes from the troughs that one sees during the replacement therapy. We do know that there is poor bleed protection with the current prophylaxis if one is using replacement therapy, despite perhaps the full toolbox and the abundance of the therapies as I indicated in the previous slide, we do still see deterioration, the musculoskeletal outcomes in our patients. And the best example of this is patients that started prophylaxis some time back. The bottom line is that the musculoskeletal deterioration is not halted despite the prophylaxis. And of course, we've got disease-specific unmet needs such as hemophilia B prophylaxis, where we currently did not have a subcutaneously administered agent. And gene therapy has many limitations. Having done a few of these, about 30 of our patients have undergone gene therapy. Now I understand that it is not the answer to any or all of these unmet needs. It is in that context that the non-factor therapies have been developed. And for simplicity, I've classified this into 4 groups. They include a monoclonal antibody directed against activated protein C, the monoclonal antibody directed against tissue factor pathway inhibitor, of which currently there are 2, and in the future there may well be 3 or 4 molecules. And then we've got the small interference RNA that down-regulate the production of antithrombin, as well as a number of factor VIII mimetics. We currently have several of these factor VIII mimetics that are evolving, and in fact, most of them have actually completed the phase 3 studies. Perhaps at another time, we can talk about what has been the impact of the phase 3 efficacy and safety data from the factor VIII mimetics. And in fact, I want to perhaps remind for those of you who are not in the field as to what mechanistically is important about each one of these molecules. Let's start off with the thrombin generation and the use of tissue factor pathway inhibitor. It is a relatively versatile molecule that we know has a number of impacts. It interferes with the generation of activated factor 10. It certainly is important for the formation of the tenase complex, and certainly the prothrombinase complex, and it interferes with the factor 7 activating protease complex. And then finally, it has got a number of other functions, amongst which it is interfering with the activated factor 10 tissue factor complex, as well as many others outside hemostasis. And I want to remind you that if one were to take this understanding into a test tube, one sees the typical dose response that would expect as one increases the amount of tissue factor pathway inhibitor. You can see the level of thrombin generation also increases. In some instances, in fact, at 10 milligrams per liter, you can reach supraphysiological levels, which, of course, in the context of human beings, is never desirable. And we'll talk about later as to why it's never desirable. So the proof of concept here is that in a test tube, at least, one is able to generate thrombin, which I referred to earlier on as the central ballerina of hemostasis, and certainly something that we are all aiming to accomplish when we put patients under any therapy in hemophilia. Let's move on now to the antithrombin. The antithrombin, in fact, acts at a cellular level. You can see that under normal circumstances, the molecule is taken into the cells. These are hepatic cells. It undergoes a number of changes within the cells, resulting, of course, in a recycling pathway. And the bottom line here is that during the course of the cytoplasmic traversing here, the molecule, which is the antithrombin, is able to down-regulate the production of antithrombin, and consequently, one is able then to unblock the natural blockade that happens in a human being, of course, resulting in the rebalancing of hemostasis. So fluticasone downregulates antithrombin to restore sufficient thrombin generation and rebalance hemostasis in hemophilia. It is given subcutaneously monthly in a prophylactic fashion. And of course, it has been shown to be active in both hemophilia A or B, with and without inhibitor, which is the subject of today's discussion in the context of non-factor therapies. What about the factor mimetics? We do know that the factor VIII is a large molecule, a multi-domain molecule that brings together activated factor IX and factor X to form the tenase complex, and the downstream effect, of course, is the formation of the prothrombinase complex. In the absence of this cofactor, it is not an enzyme, it's a cofactor. One is able to replace the factor VIII with a bispecific monoclonal antibody that is capable of functioning exactly the same as factor VIII. And the downstream effect, of course, is the generation of the tenase and the subsequent prothrombinase complex and the clot formation. It has a number of remarkable characteristics in that it doesn't just only replace the missing factor, but it does so even in the presence and the absence of inhibitors. So it is agnostic to the presence and the absence of inhibitors. It can be used in either settings in order to be used prophylactically in patients with hemophilia A, with and without inhibitors. So you will agree that it will take me an hour, 2 or 3 hours to go through each one of these molecules in taking you through what is available currently. So I've decided to be strategic and maybe focus on one of these molecules and then take you through the data and hope that at the end, when we have time during the question and answer session, you'll be able to ask about any of these molecules. Of course, the data is out there available. So I'm going to focus for the rest of this presentation on one of the non-factor therapies, and that is concizumab. And I'm going to take you through this schema, specifically reviewing with you the efficacy and safety data from the phase 3 studies, and perhaps asking very basic questions. Does concizumab not increase the treatment burden or not? And I'm going to take you through the data that talks to whether daily dosing is burdensome or not. And also, can one do surgery whilst you are on concizumab? And how do you manage breakthrough bleeds in patients who are currently on concizumab? We could do the same, in fact, with any one of these molecules if time allowed, and it wasn't this late in the afternoon when, in fact, people are ready to go and rest. Let's start off with perhaps the clinical trial program for concizumab. It's indeed a very comprehensive, detailed program comprising of no less than 8 clinical trials. The aim here is to show you that these clinical trials were designed and formulated to address both patients without inhibitors as well as patients with inhibitors. For the patients without inhibitors, there is at least 6 such clinical trials. You can see in the light blue, these are the clinical trials that have been completed. And in fact, in the dark blue, the Explorer 8 is currently in the extension phase and ongoing. And some of those results, in fact, have been presented. Notably, you can see the very large number of individuals that are currently in the Explorer 8 phase 3 study. Perhaps more importantly, to point out that this is an ongoing evaluation of the efficacy and safety of concizumab in the context of those without inhibitors. What about those with inhibitors? There's been a number of studies that have been conducted, both completed and ongoing. The ongoing study is the Explorer 7, where both inhibitor patients who are a large number of them, in excess of 140, have the evaluation done in terms of the safety and efficacy at the end of the day. And I want to remind you that apart from a clear distinction between those with inhibitors and those without inhibitors, there are other programs in which concizumab is used as a therapeutic agent. That includes individual patient basis requests that are granted by Novo Nordisk, and the compassionate use program that is currently ongoing. And we are currently in the process of finishing the Explorer 10, which is specifically designed for the pediatric population, evaluating concizumab safety and efficacy in the pediatric population. So you'll agree with me that, in fact, this is a comprehensive development program with many studies, and some of which are currently ongoing. Of course, we do have a fairly large database from which we can refer and share the experience. And I want to jump over now to the dosing regimen. You will recall that concizumab is given on a daily basis. And this is the schema actually for the dosing of concizumab. You have a loading dose, then followed by the maintenance dose. The loading dose is usually a standard dose of 0.2 milligrams per kg. And at the end of 4 weeks, one then gets the opportunity to evaluate and see where the dosing, the level of concizumab is in the plasma. If the level of concizumab in the plasma is less than 200 nanograms per ml, the dose is then increased to 0.25 milligrams per kg from 0.2. If the level is above 4,000 nanograms per ml, the dose is decreased to 0.15 milligrams per kg from the 0.2 milligrams per kg. Perhaps to emphasize again that the loading dose is a standard dose of 1 milligram per kg that is given weekly over a period of 4 weeks before evaluation. And I want to perhaps take you through the rationale for giving concizumab on a daily basis as compared to other non-factor therapies which are given on a weekly and sometimes on a monthly basis. And the real reason is because of the so-called target-mediated drug disposition, TMDD. The PK profile of concizumab is non-linear, and it is associated with a very high within and between patient variability in the drug exposure. This is partially shown by these graphs here. As you can see, one is looking at time as a function of the concentration of concizumab. You can see that, in fact, the PK profile is very non-linear. Perhaps for the people who have not heard of the terminology before, TMDD is when a drug binds with a high affinity to its target, and subsequently the drug target complex is eliminated to such an extent that it affects the PK. In fact, this effect you see here is as a result of the drug target complex being taken out of circulation. This elimination pathway is saturable due to the limited number of targets, of course, on the cell surface, and hence the PK of the drug becomes non-linear over time. Concizumab, the elimination is the binding of the concizumab to the endothelial cell anchored TFPIs, which then is followed by endocytosis and degradation. All of these molecules, of course, end up inside the cell in the cytoplasm. And I want to perhaps then switch over now that I've justified why concizumab is and should be given on a daily basis. What has been the impact on efficacy when it is actually given on a daily basis? This is the data taken from the phase 3 Explorer 7 study. Daily subcutaneous prophylaxis with concizumab resulted in a significant reduction in ABR when compared to no prophylaxis. And this is illustrated in this graph here, showing no prophylaxis and concizumab prophylaxis. as well as the estimated mean ABR for treated spontaneous as well as traumatic bleeding episode, you can see the reduction here of an ABR from no prophylaxis perspective of 11.8 to an ABR of 1.7. And in fact, the difference in terms of the reduction in the ABR was statistically significant, and the ABR ratio was very low at 0.14. And if one looks specifically at the median ABR as opposed to the mean ABR, you can see that there was a significant reduction, and the median ABR was 0 on concizumab prophylaxis when compared to no prophylaxis with an ABR of 9.8. And the difference, of course, is also very clinically relevant and significant. So the proportion of individuals who were on concizumab prophylaxis that did not bleed at all was very high. It was 21 out of the 33, in other words, 64% of the patients had 0 bleeds. Just to remind you that if one is using replacement therapy, that number is somewhere between 27 and 39%. So there's actually almost a doubling of the proportion of individuals receiving concizumab prophylaxis who achieve 0 bleed rate when they are on concizumab prophylaxis. And if one looks at the efficacy by bleeding subtype, this is illustrated in this relatively complex table, and I must apologize for it, but I think one could summarize it by saying, compared to no prophylaxis, if we are looking for treated spontaneous or traumatic bleeds, treated spontaneous bleeding episode, joint bleeds, target joint bleeds, you can see that, in fact, there is a significant number of annualized bleed rate that one is able to achieve. Whereas if you are looking at concizumab prophylaxis, whether one is looking at a subset of 33 or 114 patients in group 2 or group 2 to 4, you can see that by and large, for most of these bleeding subtypes, the ABR is 0. And if one looks at all the treated and the untreated bleeds, you can see that overall, one is looking at an ABR of 2.2 to 2.6 in general. So improvement in patient-reported outcomes were observed with 26 weeks of concizumab prophylaxis when compared to no prophylaxis. And that included, of course, a number of other parameters that I'm not going to have time to show today, and that includes the general health, the health-related quality of life, the treatment burden, and the treatment preference for these patients, which data is particularly exciting, more than the primary efficacy data of safety and efficacy. I want to switch over now to Explorer 7. As you will recall, this is a cohort of individuals without inhibitors. What was the impact of concizumab on the bleed rates? In fact, it was not different from Explorer 7, where you can see that for the individuals who are on concizumab prophylaxis, hemophilia A compared to hemophilia B, the estimated mean ABR was significantly lower when compared to those who were not on concizumab prophylaxis. In other words, were on previous prophylaxis, the ABR being 19.3 for hemophilia A and 14.8 for hemophilia B. And I want to perhaps call out here the median ABR was very low for those who were on concizumab prophylaxis at 2.9 and 1.6 for hemophilia A and B when compared to 19.6 and 14.9 for hemophilia A and B for those who were not on concizumab prophylaxis. And the patients with 0 bleeds, in fact, continue to be very low in the context of the patients who were receiving concizumab prophylaxis. There was an 86% reduction in the bleed rates in those who were receiving concizumab prophylaxis with hemophilia A, and 79% in those who were receiving concizumab prophylaxis with hemophilia B. And if one were to examine the secondary endpoints, in fact, they sing the same hymn of a reduction in estimated mean ABR. And I will summarize here by saying, one is looking specifically at the median ABR, whether one is looking at hemophilia A, hemophilia B, you can see that the bleed rates actually very, very, very low in these patients. And that was actually analyzed and shown to be non-inferior to the standard of care in the intra-patient analysis that actually was part of the protocol and needed to be evaluated. So from the efficacy perspective, you'll agree with me that we've got fairly convincing data from both Explorer 7 as well as Explorer 8 with regard to its efficacy, and this efficacy seemed to be agnostic to the hemophilia type, equally efficacious in hemophilia A and B with and without inhibitors. The most important evaluation, of course, in any clinical trial is the safety, and this is the combined safety data from Explorer 7 and Explorer 8. You'll note that it's a relatively large number of individuals that were exposed to concizumab, 127 in Explorer 7 and 151 in Explorer 8. And this was done at 56 weeks across the 4 arms in both of these studies. And perhaps to summarize here, the most important outcomes of the safety were that the injection site reactions on pain experienced, in fact, was comparable to what we already know at the prevalence of 24% and 17%. And of course, the equivalent of 0.4 and 0.2 events per year in these individuals. So if you had individuals, 100 individuals that were followed over a period of a year, one would record at least less than 1 event per year across if they were receiving concizumab on a daily basis. More importantly, there were no thromboembolic events that were reported following the trial restart. And I want to remind you, during the conduct of the Explorer program, there was a stop when individuals developed thrombosis, and mitigating measures were put in place. Which mitigating measures, in fact, was the schema of the dosing that I showed you right at the beginning. And in fact, after the implementation of the mitigating measures, there hasn't been, in the context of this clinical trial, any thromboembolic event. And I want to remind you that hypersensitivity reactions were very few, occurring only in 2 patients out of this very large number of individuals. There were no hypersensitivity reactions in Explorer 8, and the 2, in fact, occurred in Explorer 7. You can see here that there were a number of these thromboembolic events that were seen before the mitigating measures were put in place. And once the mitigating measures were put in place, there were no thromboembolic events that were seen. And I want to remind you that part of the safety measurement is immunogenicity. There was a fairly large number of individuals, both in Explorer 7 and Explorer 8, who developed anti-drug antibodies. And the good news that those anti-drug antibodies did not have an effect in the efficacy and the pharmacokinetics of concizumab in the context of this drug. And I want to expand here that these were measured both from just the anti-drug antibody perspective, but also from the neutralizing effect perspective. There were 33 individuals that developed anti-drug antibodies, of which 8 actually had an in vitro neutralizing effect, and none of these translated into an impact on the pharmacokinetics or even the safety and efficacy in the patients that received the drug. And I've yet to come across data that talks to neutralizing antibodies in vitro becoming neutralizing antibodies in vivo in these patients. I want to perhaps remind you and perhaps reassure you that in Explorer 7, over a period of time, one looks at the exposure range. You can see that, in fact, the exposure range is quite stable over time. If you start off by giving that 1 milligram per kg loading dose, you can see that it remains stable over time. And you might actually just recall that was one of the unmet needs of replacement therapy, characterized, of course, by the peaks and troughs. And what we've done here with concizumab, we've essentially abolished the peaks and troughs, and it's a steady state hemostatic cover. So a single dose of 1 milligram per kg leads to a steady state that is stable over time. And then secondly, if one specifically looks at the free tissue factor pathway inhibitor, again, one sees a once-off drop following the loading dose and then a steady state subsequently, which is quite remarkable over time. And then finally, if one were to specifically look at thrombin generation, you must remember this is a non-factor therapy capable of thrombin generation. One is able to generate thrombin, and that thrombin that is generated, if you continue a daily dosing of concizumab, you can see that it remains stable over time. There's no fluctuation where it goes up and down. And that's actually very much reassuring from the pharmacokinetic and the pharmacodynamic perspective that one is able to address at least some of those unmet needs that I alluded to earlier on. And I want to switch over now to a very practical question. And the first question that often get asked is, does repeated dosing with concizumab carry any risk, or is it safe? And the bottom line here, in fact, I've put together the data from the pharmacodynamics and the pharmacokinetics, specifically looking at the D-dimer, the prothrombin fragment 1 and 2. And this is actually plotted against the concizumab concentration. You can see here that with regard to the D-dimer, there may well be a slight correlation between the dose as well as the D-dimer level. But the level actually does not reach levels at which one gets very worried and wants to stop the drug. And the same with the prothrombin fragment 1 and 2. You see almost a correlation that one can see there. What about the fibrinogen? You know that the fibrinogen is the raw material actually for the thrombin generation. You can see there's no correlation whatsoever. There were no changes, at least from the lab perspective, that were seen with regard to fibrinogen. What I haven't shown you is also there was no change with antithrombin, and there was no change with platelets that were seen over time. And to perhaps go back to the question, does repeated dosing with concizumab constitute a safety risk? And the answer, based on these pharmacokinetics and pharmacodynamic data, it doesn't look like it's the case. In fact, one can be rest assured none of these translate into deleterious safety profile of the patient. The next question is, does repeated dosing increase the treatment burden? In other words, are we burdening patients by asking them to inject themselves on a daily basis? And to answer this question, I want to bring to the fore a tool that is used to measure the treatment burden. It's called the Haemophilia. It is a novel tool. It has a number of characteristics. It measures the treatment burden. It is a 5-domain, 26-item tool. The response scale is from never to always, or not at all to extremely, and scores ranging from 0 to 100, with a lower score. Just remember that lower score translates to lower burden. Higher score translates to higher burden. Of course, there are additional detail on the development and the validation of Haemophilia, which I will not go into now. And I want to perhaps just take you straight into the 5 domains of the Haemophilia. This represents the total score. Of course, the other domains will be the injection difficulty, the physical impact, treatment bother, interference, and emotional impact for the individual that is injecting themselves. And these individuals needed to complete the score. And when one is looking at the outcomes of the Haemophilia evaluation on concizumab compared to Novo-7, Eptacoc alpha, just to remind you again, the lower the score, the lower is the burden of treatment. Starting with eptacoc alpha, you can see that, in fact, it does carry a fair amount of treatment burden if injected. Doesn't matter how often one injects it. Compared to eptacoc alpha, concizumab significantly carries a very low treatment burden. And that is actually very much reassuring that we are not increasing the treatment burden for the patients. This is now patient-reported. It's not treater or sponsor reported. The patients themselves actually rated whether the treatment burden was increased or not. And if one were to dig deeper into the subtypes of hemophilia to see if there was any difference, you'll agree with me whether one is looking at hemophilia A or B with inhibitors, or one is just looking at hemophilia A without inhibitor. The treatment burden as reflected here by the very low Hemotherm score is in keeping with a very low treatment burden that the patients reported during the course of the conduct of these studies. This data, in fact, is taken from one of the studies I showed you earlier on, Explorer 4 as well as Explorer 7. The bottom line is that they're all using the same molecule, which is concizumab. And I hope I've convinced you that we're not increasing the treatment burden to the patient. In fact, the patient themselves told us that the treatment burden is not increased. The next question, I think the most important question, is, can patients on concizumab undergo surgery? And the bottom line is, I've listed here and outlined some of what I consider to be the principles that one needs to follow in patients undergoing surgery when they are on non-factor therapy. These are some of the principles that I myself follow when I am taking patients to surgery. One is to confirm the bleed type and severity. That is very important because that determines whether the patient will need additional hemostatic agents or not. And in the context of concizumab, the recommendation is that there must be a temporary stop. And of course, there is a reason for it. Reason is because one needed to go through the phase 3 study, not because it was dangerous, partly because one needed a clean data set. One needs to choose the appropriate additional hemostatic agent that you need. Once you've stopped the concizumab, you give the lowest dose of that agent, you avoid contraindicated agents, and you avoid combination that leads to thrombin generation, and you monitor clinically and using the lab where appropriate and necessary. And we can talk about later as to whether it is appropriate and necessary to monitor when one is getting concizumab. And one needs to make a distinction, and that is very important, the distinction between major and minor surgery. And I've formulated my own list of what I consider to be minor surgery. These are shown here: circumcision, cystoscopy, colonoscopy, pleurodesis, cataract removal. In my view, the fine needle aspiration, they're all minor surgeries. Whereas major surgeries will be multiple tooth extraction, synovectomy, total knee replacement, bone and muscle debridement, osteotomy, as well as pseudotumor surgery of any nature would be considered to be major surgery. And I encourage each one of you to basically take time and make your own list. There is no officially endorsed or available list of major and minor surgery. It's all your perception as to, in your own environment, with your capacity and the hemostatic agents that you've got, what do you consider to be major and what do you consider to be minor surgery? What about the outcomes of surgical procedures in patients who had concizumab in Explorer 7 and 8 who underwent surgery? These are some of the data set. A total of 278 patients were included from Explorer 7 and 8. And you can see that if one specifically looks at the minor surgery, concizumab prophylaxis was continued during the perioperative period when patients were undergoing minor surgery. There were a total of 38 minor surgeries in 30 patients. You can see that the majority of these minor surgeries were dental procedures. There were 3 colonoscopies. There was 1 arthrodesis, and there were others which were none of the ones that were mentioned above. For the major surgery, at least planned major surgeries, No, the concizumab was stopped. There were 7 major surgeries that were undertaken in 7 patients that needed the surgery. These are the 7 major surgery. There were 2 arthropathies that needed replacement. There were a total of 2 total knee replacements. There was a fracture, a hematoma drainage, and a diagnostic laparotomy, which was considered to be a major surgery. And perhaps to summarize, how were they managed? If one specifically looks at the minor surgery, of the 14 minor surgery related bleeds, they were all mild or moderate in severity. And in fact, only 1 was a major or severe bleed during the minor surgery in the context of the 38 minor surgeries that were conducted. 21 of these minor surgeries, in fact, required treatment with factor. In other words, 8 out of the 38. One was a patient who had braces that needed to be manipulated. There was a patient with dental implants, as well as the patient with dental extraction. And I just want to caution you, whilst I regard dental procedures to be minor, one also needs to take into account what procedure do you want to do. You can see that, in fact, for the minor surgeries, the patients could undergo the surgery safely without any deleterious effect. The majority of these surgeries, in fact, the bleeds were mild or moderate, and most surgery-related bleeds had a low bleed duration. And the most common minor medical surgical procedure, in fact, were dental procedures. I just wanted to contrast this to another anti-TFPI, which is mestacimab. And perhaps the bottom line here, and in fact we can have a whole lecture on mestacimab, is that just to give you the reassurance that it doesn't matter which non-factor therapy you may want to use, or at least which class you want to use, surgical procedures are actually possible. And I want to take you through each one of these. Suffice to say that the same sort of rules apply. You do need to separate major from minor surgery. And for the major surgery, and of course, mestacimab was stopped. And for the minor surgery, it was continued. And the outcomes, in fact, were very, very good overall. The next question, and probably the most important question that I want to end with, how do we actually manage breakthrough bleeds in the context of these patients? We do have guidelines that have been published in the context of concizumab. These are guidelines for both participants in Explorer 7 and 8. And the guidelines are actually very detailed. If you are using standard half-life or extended half-life factor 8, the lowest approved dose that you can use is 20 units per kg. If you are giving standard half-life or extended half-life factor 9, it's 30 units per kg. If you're giving an inhibitor patient a recombinant factor 7, 90 mics per kg. If you're giving an inhibitor patient an APCC, a single dose not to exceed 50 units and no more than 100 units in any given 24 hours is what is recommended. And if you're using some of these products that have got a combination of activated 7 and 10, the recommended dose is a single dose not to exceed 6 micrograms per kg. And the most important message is that patients need to contact the center before initiating additional treatment needed an additional hemostatic agent. I want to switch over now to if the patients in fact had bleeds during concizumab prophylaxis, where were those bleeds and what was their severity? If you take the data from Explorer 7 and Explorer 8, you can see that the majority of the bleeds, in fact, remained the hallmark of hemophilia, which is the joint. Most of the patients did not bleed anywhere else other than bleeding into the joints. As you can see here, it really didn't matter whether you're dealing with hemophilia A or hemophilia B with or without inhibitor. That was still the most common site. And the question that needs to be asked next is, what was the severity? You can see that there is a paucity of severe bleeds across the board. The majority of the bleeds, in fact, were mild and moderate in severity. as opposed to a very small number of individuals that actually had severe bleeds. And in fact, if we were to summarize the mild and moderate bleeds and ask the question, how many doses did those need? You can see that most of them, in fact, were resolved with 1 or 2 injections at a time. There were very few individuals that needed more than 3 or more injections in the context of factor VIII. What about the inhibitor patients receiving the recombinant factor VII? The tendency was the same, 1 or 2 injections, and the same with an APCC. In fact, with the APCC, we were surprised that most patients, at least in the context of this cohort, required 3 or more injections in order to manage mild bleeds, which is unheard of, at least unprecedented. And then the last question, I just want to give you my free thoughts about the non-factor therapies. They're here to stay. The bottom line is we can't get rid of them anymore. And I'm not worried about efficacy because I think efficacy is resolved or solved. They are efficacious. The question is safety, and we need to get the balance right between efficacy and safety. And how do we do that? One needs to obviously be aware of the potential of bypassing agent to increase thrombosis. We do need to avoid stacking the therapies. And in fact, in my view, if you've got protocols, you need to stick to those protocols in order to avoid disasters, such as taking a person with hemophilia and anticoagulating them, which is almost never heard of. And I've had to do that, and it's a very difficult balance to make. So in conclusion, I hope I've taken you through what I consider to be the hallmarks of non-factor therapy. Specifically, I've focused on concizumab, just to remind you that the non-factor therapies, they represent a major paradigm shift in hemophilia management. They offer sustained thrombin generation independent of factor replacement therapy, and specifically the tissue factor pathway inhibitors as well as the fitusiran. They achieve a very broad procoagulant effect, which data, in fact, is currently available if you want to read more. And the phase 3 data that I shared with you from Explorer 7 and Explorer 8 on concizumab is very much reassuring that these molecules are very efficacious in bleed prevention. And in my view, at least they don't increase the risk of safety in these patients. My prediction is that the future landscape will lie in us embracing these non-factor therapy regimens and, in fact, integrating them into what we already have as framework for durable and safe hemostasis going forward. With that, I would like to stop there. Moses, back to you, and I would want us to go into the question and answer session.
Thank you so much, Prof. That was quite an interesting, concise presentation. Now our question and answer session has started. If there's anyone who has got questions, you can raise your hand or you can put your question in the chat box. And maybe whilst people are still thinking about their questions, maybe 1 or 2 questions from me, Prof. So before major surgery, when would you stop concizumab? How many days before major surgery?
Thanks, Moses. That is a very important question, which details I've not had time to go through. But in general, we tend to say if you don't want any of these hemostatic agents to interfere with your surgery, you need to stop and allow 5 half-lives of the molecule before you start. And of course, we know that especially emergency surgeries, they don't read textbooks, they don't read PK profiles. As long as you don't give the dose on the day when you are giving when you're doing your surgery, to me that is actually more than enough. In the context of patients undergoing surgery in our center, we just stop the night before and then we carry on with the additional hemostatic agents. That worked fine. there were no deleterious effects. There were no side effects that we saw. But in an ideal world, you want to allow at least 5 half-lives if you really want to get rid of the drug completely in the system. And in fact, that is not always practical or possible.
Thank you, Prof. Another one that I have is, can you combine these with a drug such as tranexamic acid?
Excellent question, Moses. Whilst I cautioned against stacking hemostatic agents, at least pro-hemostatic agents, what has been demonstrated repeatedly, both in vitro as well as in vivo, in the patients that have undergone surgery, at least in our center and others, is that one is not getting a synergistic effect of combining any of these agents with antifibrinolytics. So you can and should be able to combine them, particularly in settings such as arthroplasties, where tranexamic acid, in fact, has become the standard of care to give to patients undergoing arthroplasties. But also for all mucous membrane-based bleeding, one would expect that the presence of an antifibrinolytic will only enhance the hemostatic effect. It can't do any harm. And we know from the in vitro data that we're not getting a synergistic or an additive effect.
Thank you, Prof. I see Prof. Chapanduka there. Prof. Chapanduka, you can unmute and ask your question. Prof. Chapanduka, you're still muted.
Moses. Oh, thank you very much, Dr. Chatambudza and Prof. Mahlangu. It wasn't allowing me to unmute. That's why the delay. Johnny, that was very comprehensive, and I certainly enjoyed it. I've got some very quick questions. The first one, well, they are both around the developmental pipeline in terms of what's still in the clinical trials. First question is general. What is the most promising next agent in this area? I know some are in advanced clinical trials, especially the MIM8.
You always ask
So which
that requires me to have extra brain cells, okay, which I don't have. But honestly, to answer your question, one needs to have a crystal glass that can look into it. The bottom line is we are in an evolving therapeutic landscape. And in fact, when I started with the non-factor therapy, that was 2016, exactly a decade ago, I thought, geez, this was actually much better than sliced bread at that time. And in fact, we in NS embraced and enroll just over 100 patients in Haven 1 to Haven 6. And my thinking at that stage, Z, was this is the end. And of course, I was completely wrong. I was completely wrong. We currently have 11 therapeutic agents, some of which are in phase 1, phase 2 studies. Others have completed phase 3 studies. So to answer your question, which one is the most promising? Just give me another 2 years. When we've got all of the phase 3 data, I'll be able to give you an educated answer. At this stage, I don't know. What I thought in 2016 was the best therapeutics, and in fact, it turned out to be the global standard of care. Suddenly, it's not the best therapeutics because there are many more that are coming because of this evolving therapeutic landscape.
Great stuff. Thanks, Johnny. The second question would have followed on that, but that's perfect. Thanks.
Prof, there is a question from Charlene there in the chat box. How would one manage a patient with acute myocardial infarction on the newer non-replacement factor therapies?
Now, Charlene, that is an important question, and touch wood, some of us have not had that. The bottom line is, maybe I could just put this into perspective. The way we managed patients receiving replacement therapy who happened to be unlucky and they had an MI has now been established, and in fact, it's used around the world. What you do is you do not stop the hemostatic agent. You actually, if anything, you optimize it so that you can give the appropriate additional therapies. You do know that one needs an anticoagulant and antiplatelet on top of the pro-hemostatic agent. In fact, I've had 2 patients with MI in the days of replacement therapy, and that's actually the procedure that we followed. These patients, up to now, they are alive. They are still continuing with prophylaxis with replacement therapy in addition to the MI therapy that is required. The only thing that we needed to adjust was the patients had too much bruising. So instead of giving 300 milligrams of aspirin, we're giving currently 75 milligrams of aspirin. But the patient is getting everything else, just like the patient without hemophilia. Obviously, only experience will tell whether taking that strategy into non-factor therapy will be different or will be the same. My suspicion is that, in fact, it's likely to be the same rather than different.
Thank you, Prof. I don't see any other question there. Maybe I can just ask one more question. So now, with the data which is showing quite effectiveness of these non-replacement therapies, what do you think about the pharmacoeconomics side of it, especially in an African context whereby we are having challenges accessing the basic replacement therapies for our patients, prophylaxis?
Yeah, I mean, today is Africa Day. I'm actually wondering why South Africa is not celebrating Africa Day. But anyway, that's a different question, Moses. The bottom line is that we were probably the most affected from the pharmacoeconomic perspective compared to many parts of the world. And my take on it is all of us need to roll our sleeves and make sure that many more of these molecules actually come to the fore. And the thinking behind it is a very simple one. The more of these molecules we have, the more likely that they will complete amongst themselves, not from the safety and efficacy perspective, but from the affordability perspective. And we're going to likely see the prices coming down over time. So from that perspective, I'm very hopeful. And I'm here using my very narrow lens of being at Charlotte Maxeke, doing currently about 11 or 12 clinical trials on these molecules. And I'm keeping on pushing that every one of them will see the light of the day so that there will be enough competition for us to get the benefit of a competitive playing field across the board. That's the one component of it. That basically maybe is my naive approach. The second approach, Moses, is we did extremely very well during the COVID. We suddenly had experts that I didn't think existed. We had the resources that I didn't think existed. And in fact, they were very quickly put together. I think the next phase is basically to take ownership of some of this technology and start to produce them in resource-constrained setting. And if we do that, and India has been very good at doing that, if we do that, my take is that we'll not regret why, in fact, they were developed in the first place. It's only when we fold our arms and basically put out begging arms and doing nothing that we are actually going to perpetuate the current status quo. So I don't have an answer to your question, but I'm very optimistic. I'm actually an optimist through and through. I'm hoping that either of those, in fact, will come on our show and will be able to afford these molecules going forward.
Thank you so much, Prof. I think I like the example of India that you just gave there, that we really need to produce for ourselves. I see two more questions? One from Darlene there. It says, I presume the laser interference with coagulation tests seen in concizumab is a benefit. Does the impact on lab tests play a significant role when these agents are weighed against each other? That's from Darlene.
Very good question. In fact, I was hoping that someone would ask the question. I initially put in the slides on monitoring, etc., and I took them out because I'm very respectful that we are nearing the end of the day. Having a lecture for an hour is a little bit of asking too much, and prolonging it to half an hour and an hour and a half, etc., might be traumatic for some people. But to answer your question, it is an advantage, I agree, given that other molecules interfere with the clot-based assay. Specifically, the factor mimetics seem to interfere with every clot-based assay. Here, we don't see any direct interference with any of the assays that we do. Not that we want to measure anything in particular, but I think it's important that if you're going to take the patient for surgery, at least get a baseline inhibitor level, or get a baseline factor 8 or baseline factor 9. And you don't need a special test to be able to do that. Whereas if someone is on one of the factor 8 mimetics, you do need a homogenic factor assay to be able to get an accurate reading of all of the clot-based assay, including the PT, the PTT, the factor 8, the factor 9, etc., etc. Yes, I agree with, I couldn't see the name here, with Darlene, that yes, it is an advantage. And thanks for that insight. And I apologize if I sort of misjudged. I should have left the slides on. I think there is a next question there, Moses.
Yes, from Frederick. I think we once had a discussion about that when I was still a fellow in your unit. What are your thoughts about possibility of benefits for anti-TFPI? Maybe indeed also include things like emicizumab as well in bleeding prophylaxis in acquired hemophilia A?
Yeah, thanks, Frederick. That's an important question. It's a question that is on our mind all the time, because acquired hemophilia is an absolute nightmare for anyone looking after the patient, and certainly for the patient who often cannot predict when it's going to lead to bleeding. I don't have any personal experience at this stage. Obviously, I'm using these molecules in the context of clinical trials, but I think that there is a potential. Just to put this comment into perspective, particularly Moses, your comment, we've come a long way. We are currently doing a clinical trial looking specifically at a factor 8 mimetic in acquired hemophilia in the context of clinical trial. These are not anecdotal. This is not off-label use. This is ultimately going to generate data that will allow us to be able to use it. And in fact, over the weekend, Moses, we happened to have another meeting where we had a guest speaker. His name is Cedric Hermans. He's the current VC, the vice president of the World Federation of Haemophilia. He's based in Belgium. In my conversation with him, he's actually treated more than 30 acquired hemophilia with a factor 8 mimetic. And he swears by it. He basically says it works. Even though we're doing studies now, there is now clear evidence that it is a no-brainer to use it. And the way he uses it, in fact, it's actually quite intuitive. You give a loading dose of 6 milligrams and then the standard maintenance dose, and that seemed to work. extremely well. So to answer your question, I don't have any personal experience with anti-TFPIs, but I suspect that we're probably going to go the same route as the factor VIII mimetics.
Wonderful. Thank you so much, Prof. I think all the questions have been answered, and that just leaves me to thank you so much and thank all our colleagues who joined us. At some point, we were almost 180, which is quite a big audience. And thank you so much, Prof, for giving us such a great talk. And
Thanks
to everyone,
Thanks to the organizers and to Novo Nordisk for bringing us together. Have a good evening.
Thank you. Good evening.